Okay, so I think we are ready to go. So again, dear all, welcome. I'm Mariangela Pellegrini. I work for the ERN-EuroBloodNet, European Reference Network on Rare Hematological Diseases. And I'm really honored to welcome all of you on behalf of the ERN and also on behalf of the European Haemophilia Consortium that has coordinated and planned with us this educational program. And with us also, we have had our ePAG, so our European patient representative, Baiba Ziemele, who is our connection with the European Haemophilia Consortium. So this educational program has been really a conjoint project, also because we could count on the partnership of EURORDIS-Rare Diseases Europe, and it has been supported by members of the scientific committee as Professor Sophie Susen, Professor Jeroen Eikenboom, and Professor Flora Peyvandi. And our aim is really to disseminate knowledge, up-to-date knowledge among interest, hematologists and healthcare providers, but also patients and patients organizations. And on this, I'm glad to pass the floor to my colleague, Daria Camilli, for introducing to you the European Haemophilia Consortium. Thank you, Daria.
Thank you, Mariangela. I'm Daria Camilli, Education and Communication Manager at the European Haemophilia Consortium. And before I introduce our organization, I would like to thank, on behalf of the EHC, the ERN-EuroBloodNet for cooperation and for ability to create this truly unique project together. And European Haemophilia Consortium is an international non-profit organization. We represent 48 national patient organizations for people with rare bleeding disorders from 27 member states of the European Union and most member states of the Council of Europe. The EHC represents approximately 90,000 people diagnosed with a rare bleeding conditions such as hemophilia, von Willebrand disease, and other rare bleeding disorders across Europe. Among those, von Willebrand is the most common bleeding disorder, affecting up to 1% of the general population. However, it is often neglected and overshadowed by hemophilia. So this program aims to distinguish von Willebrand disease from hemophilia and focuses on the particularities of this specific bleeding disorder. Within the framework of this program, we are going to discuss very topical areas related to von Willebrand among patients and healthcare professionals, and give visibility to the challenges of those living with this rare condition, including quality of life, access to treatment and care, medical services available in Europe, diagnosis, treatment options, and the overall patient journey through life. And this is our second webinar. And today we're going to talk about genetics. And I pass the floor back to Mariangela.
Thank you very much, Daria. So indeed, before arriving to today's lecture, I want to share with you some information. The first one is that this program is accredited by Continuous Medical Point, issued from the European Body of Accreditation in Hematology. It's 1 credit per webinar. How to request them? It's very easy. So just pay attention that you use the same email when you register to the webinar and when you enter the webinar, because you have surely noticed that there is a double inscription. This is a way for us for tracking your presence. And also at the end of the webinar, you are going to receive satisfaction survey. So please answer it. And then we will contact you for with the instruction of how to formally request credit. So do not worry, we will contact you. Then some home rules also. So this session, as you can see, is recorded because all the video of this program will be implemented in our e-learning environment. So from the ERN and also from the patient's organization. So you will have full access on this material. But if you feel not comfortable in being identified, please change your name in the platform, put off your camera, or just notify it to me and we will take care of it. So we finally arrive at today's lecture. As Daria has anticipated, will be about genetics of Willebrand disease. As usually, we have a duo or a trio of speakers for each webinar because we really want to provide patient-centered information. And so today with us, we have an expert, a key expert on this topic, and also a patient representative. So I will introduce Professor Frank Leebeek, who is full professor at Erasmus University Medical Center in Rotterdam since 2009. He's chair of the Department of Hematology and since 2017 is coordinating a research team on hemostasis and thrombosis with several research topics, including, of course, von Willebrand disease. Is in the steering member committee of several studies on new treatment for patients with bleeding disorder, including also gene therapy. He has been secretary of the Dutch Society of Thrombosis and Hemostasis, chairman of the Dutch Haemophilia Doctor Organization, and is currently a board member of the Dutch Society of Hematology and European Haematology Association. So, Daria, do you want to introduce the other speaker?
With great pleasure. It's Traunter, and she's a co-chair of the EHC Willebrand Disease Committee, and she's also actively involved in her national Haemophilia Society, where she works with women. And we are really proud to have her today with us. And Jo, I pass the floor to you to start this webinar.
Thank you. So, good afternoon. Thank you, everybody, for joining us. As you know, tonight we're going to talk about genetics of VWD. I think many people, like myself, in our community wonder how they inherited VWD, where did it come from, and what does it mean for their families. So I was diagnosed at the age of 37, which is really quite a late diagnosis, and I had a lifetime of bleeding episodes but with no diagnosis, and I wasn't on my own. So my brother also had these significant symptoms our whole lives, and though the symptoms were acknowledged as real by medical professionals, there just wasn't any history of a diagnosed bleeding disorder in the family, and it was only really after I'd had 2 children, and I was on my 3rd pregnancy. And in the previous 2 pregnancies, I'd had quite traumatic bleeding episodes, that those doctors, knowing I was pregnant for the 3rd time, decided that they really needed a diagnosis. And I can honestly say that that diagnosis saved my life, because it informed a treatment plan, and that treatment plan ensured that I had the correct doctors who were in the room, and that they were armed with the correct medication and the correct knowledge. But then that triggered a whole family testing to see if anybody else in the family had von Willebrand disease. And it turned out that one of my existing 2 daughters had von Willebrand disease, and my newborn baby also had von Willebrand disease. That extended out to my wider family, and found out that my brother and one of his sons had it, and my father also had VWD. But we as a family didn't really understand that diagnosis. We didn't understand the implications of von Willebrand disease. And at that point, we didn't really understand the types of von Willebrand disease that we were diagnosed with. And interestingly, actually, we were diagnosed with 2 different types of von Willebrand disease, and we didn't understand how that was possible either if this was a genetic condition. So learning about our condition, what types of treatment were open to us, and what we needed to be aware of in terms of how we lived our lives really helped us to hugely manage our conditions. And I think that illustrates from a patient perspective how important it is for patients to understand the genetics of von Willebrand disease. And there's multiple reasons. The first is really to ensure that we're making those informed decisions, that by understanding the genetic basis of von Willebrand disease, that really allows us as patients to think about our health, think about family planning, and think about genetic testing for our families. I think Secondly, it's also to understand that genetic inheritance pattern of von Willebrand disease and how this helps you as a patient, and also helps your healthcare providers to assess, what the risk is of passing that condition onto your children. But I mean, for the most part, von Willebrand disease is manageable, and with the right treatment options, most individuals can lead a perfectly normal life. But I do think that forewarned is forearmed, and it's really good to get a diagnosis and avoid those big bleeds. And we often say that often the way that people do get diagnosed in the first place is that bleeding their way through to diagnosis, and that's what we all want to avoid. I think the next thing would really be sort of treatment planning. Different types of von Willebrand disease have different inheritance patterns and implications for treatment. So if we as patients can understand the genetic basis of our condition, then that can sort of inform those treatment decisions and help you to make the right choices as an individual. Once you understand that different types of von Willebrand disease actually need different types of treatment, then you're able to educate those clinicians when you're in the room and maybe they've never even heard of von Willebrand disease. It's also, it's possible to get the family screening. So awareness of that genetic nature of von Willebrand disease really helps you to inform your family members as well about what the risk is of inheriting the condition. And, this may prompt your family members also to undergo screening and testing for von Willebrand disease. And therefore, they might actually get an earlier diagnosis than 37 and get the right treatment before it comes to the point where you've actually had an injury or something, and it's all a bit catastrophic. And I think finally, so for understanding those genetics can really make it easier for you to access that psychosocial support. And that's often missing when you've been diagnosed with a chronic condition. So, if you can understand the genetic basis of von Willebrand disease, that really provides you and your family with that sense of control and empowerment, because it's awful walking around knowing something is wrong, but just really not knowing what you can do about it. And it also it empowers you to have that communication with your family and to actually get those support networks. And really, if there's more than one person in your family who also have the diagnosis, then it allows you to have somebody to talk to and someone you can share that responsibility of managing your condition with. So overall, what I'm trying to say is, by educating patients about the genetics of von Willebrand disease, we're really leading them to, we're empowering them to be active participants in their own healthcare journey, I suppose, so that they can make those informed decisions and they can advocate for themselves and they can advocate for their families. So I'm not going to keep you much longer. I'm now going to pass you over to Dr. Leebeek, who is going to talk to you about the genetics of von Willebrand disease. Thank you.
Thank you, Joe, for introducing. And I'd like to start my talk by thanking the organizers to invite me for this lecture. I've prepared some slides which I'd like to share with you. And because the audience is consisting of both doctors working with von Willebrand disease patients and taking care of them and patients, I've made a presentation. I hope that this can be comprehended by everyone. And if you have any questions, please put them in the Q&A chat at the bottom of your screen. So I hope you can see my slides. These are my disclosures, just to be complete. And in this webinar, I'll discuss a little bit about the background of Willebrand disease, although this has also been discussed in the previous seminar. I think some rehearsal would be fine. Willebrand factor and Willebrand factor gene will be discussed, about the inheritance, what are the mutations that are found in Willebrand gene and what are the consequences, and especially related to what is important for the patients who have Willebrand disease. Do actually all patients have mutations in their genes? Is genetic testing always performed in those individuals? Is it actually needed? And in which patients is testing recommended? And afterwards we can go to the question and answer session. So just to remind us who Van Willebrand was, the disease is called after Erik van Willebrand. He is pictured here, and he was a Finnish doctor who was asked to visit and to diagnose, to make a diagnosis in a family of at the Eland Islands, and this is the family tree. And he was a very clever physician, and he made this pedigree, this family pedigree, because there were several members of this family who had severe bleeding episodes. And especially he was interested and called for this young woman, depicted in the red circle. And she was Eurydice, and Eurydice eventually died after her third menstruation because of the severe blood loss. And it was clear that there was a bleeding disorder in this family. This is more than 80 years ago. So this is a very long time ago. And you can see in this family tree that there are several members who are diagnosed with the disorder, with the bleeding disorder, and that there are also some family members or related family members who had married, and especially the father and the mother of Eurydice were related, and that led to a very severe form of Willebrand disease that eventually so many people died of the bleeding. Now, luckily, this is not the case in all Willebrand disease patients, especially at these times where you can have a good treatment. But this shows you actually what the genetics of Willebrand disease means. It's an inherited bleeding disorder, the most common inherited bleeding disorder, in which males and females are equally affected, instead of hemophilia, where males are mainly affected and females are the carriers of the disease. And the disease is characterized by mucocutaneous bleeding symptoms like epistaxis, nose bleedings, gum bleedings, hematomas, easy bruising, GI bleeding, there's gastrointestinal bleeding, but also bleeding after surgical procedures, like for instance in dental surgery, and as was discussed by Joe also, by severe postpartum bleeding that may occur in the females, as well as menorrhagia, which is seen in 80 to 90% of women who suffer from Willebrand disease. The prevalence is high. It's about 1% of the population that has reduced Willebrand factor levels and may be classified as Willebrand disease. Not everyone has symptoms of it. Sometimes it's diagnosed later in their lives because they've never had surgery, or they don't have a bleeding trauma that led to bleeding. And it's well known that this Willebrand disease is caused by a deficiency or an abnormality of one of the coagulation factors, and that is called, after Van Willebrand, as I showed you, Van Willebrand factor. What is Van Willebrand factor? Van Willebrand factor is a coagulation protein. This is a schematic representation of the Van Willebrand factor protein. Just to show you, it is built up from several domains. So it's a very big protein, and it has several domains. For instance, one domain that binds to factor 8, and factor 8 circulates in combination with Willebrand factor in the blood stream, and you can imagine if you have no fulminant factor and factor VIII cannot be bound, that factor VIII is degraded early. So many patients with fulminant disease do not have only low fulminant factor, but also low factor VIII. And that adds to the bleeding problems because that's also an important coagulation factor. You just heard that there are various types of fulminant disease. So it is caused by a reduced level of fulminant factor, and that is what we call the type 1. So you have normal fulminant factor circulating in your blood, but not enough. So it's less than, let's say, 50% of normal. Normal for healthy individuals have a level around 100%. If you have fulminant disease, you have a level less than 50%. The lower the level, the more severe the bleeding episodes. There are several types. Besides the type 1, we also have a type 2 fulminant disease, and that is caused by a dysfunctional fulminant factor molecule. So as I mentioned earlier, there are several domains in fulminant factor, and dependent upon where the defect in fulminant factor is, you can have also defective, for instance, binding to platelets or defective binding to factor VIII. And fulminant factor is important because it serves actually as a glue for the platelets that make the first platelet plug once you start bleeding. So in case of bleeding, platelets go to the site of injury, and they are attached to each other by fulminant factor. And if the platelets don't bind to fulminant factor cannot act, and therefore this leads to a bleeding disorder, which is called type 2 fulminant disease. Now, there are several other types, type 2A, type 2B, type 2N, type 2N, and I'm going maybe in too much detail, but all these different dysfunctional fulminant factor molecules have a specific phenotype, both in the laboratory assays, but also in the clinic. So for instance, type 2B, you can also have low platelets, and that also increases the risk of bleeding. Type 3 is an rarely occurring type. That was the type actually that EURORDIS had, the young woman who died early in life due to the excessive menstrual blood loss. That is caused by a complete absence of fulminant factor. So some individuals have no fulminant factor at all, and those are called the type 3. It's about 5% of all patients with fulminant disease. Now, the most important thing is the inheritance pattern of fulminant disease. That's what I'm going to discuss here. Just on the right-hand side of this slide, you can see clearly how the genetic material in our body is made. So the DNA is on chromosomes, and chromosomes are inside every cell of our body. If you have a mistake in one of the nucleotides of which DNA is built, this is called a mutation, and by one change in a nucleotide, your fulminant factor can change. This leads to abnormal proteins or low protein levels, and that causes fulminant disease. Now, we all have 23 pairs of chromosomes in every cell, and 44 autosomal chromosomes and 2 sex chromosomes. And DNA contains the genetic code of an individual, and a gene can be mutated or can be defect by, for instance, a change in one of these nucleotides, a change in many genes, for instance, not only in fulminant factor, but also in other genes that may cause low levels of fulminant factor, and rearrangement of genes or whole chromosomes. Now, in patients with fulminant disease, the problem is within the fulminant factor gene. Here you can see the gene. It's a very large gene, one of the largest of all proteins in the circulation. And you can see that these are the genes with the various, what we call exons, parts of the gene that are translated into a protein. And this is the protein that I earlier showed you with the various domains. And all these domains have different functions. For instance, the factor VIII binding is located in the D' domain. And for instance, collagen binds to the A3 domain. This is important to remember because if you look, for instance, at the various types of Willebrand disease, then in type 1, the genetic mutations can cover actually all the whole gene, leading to mutations in actually every part of this protein. That's the same for type 3, but if you look very closely, then you can see that, for instance, type 2N, which is leading to low factor VIII binding, that is mostly concentrated, as I mentioned, in the D' domain, because that's where the function of the factor for binding factor VIII is located. And for instance, type 2B is mainly located in the A1 domain. This is important to remember, and if we look, for instance, in our own study that we recently published, you can see that there are many mutations all over the gene in type 1, also in type 2, located to several domains like the A1 domain that I just discussed, or the D' domain, and type 3 also is located all over the gene. So, as I mentioned, the 44 autosomal chromosomes and 2 sex chromosomes, hemophilia is caused by a defect on the X chromosome. And that leads to the fact that if you have a female who has 2 X chromosomes, cannot have real hemophilia. They can have 1 normal chromosome and they have 1 abnormal chromosome. So one of them is defect and the other is normal. That leads to the fact that they are carriers. But a man who gets an X and a Y chromosome, he will have hemophilia. For Willebrand disease, it's different. It's located on the autosomal chromosomes, in this case, chromosome 12. And if you have Willebrand disease, and that is depicted here in this picture that I took from an educational site, you can here see a patient with Willebrand disease who has 1 normal chromosome and 1 abnormal chromosome. And if he marries to an unaffected mother, a healthy mother, you can imagine that if you combine, if this family, they get offspring, that they have one of these goes to a child, the other one goes to also to this child, and then you have an affected son, you have a chance of an unaffected daughter, an unaffected son, or an affected daughter. So in case of an autosomal dominant inheritance, and that is the cause in most type 1 and type 2 patients, the chance of getting a child with Willebrand disease is 50%, because 2 of the 4 are not affected and 2 of the 4 are affected. In case of an autosomal recessive inheritance, which is the case in type 3, you can clearly see that here the mother is carrier, the father has a similar mutation or an other mutation. In case of EURORDIS, both these parents were related to each other. They were nephews and cousin. So they had both the affected gene. So if one of the individuals gets both affected genes, both the affected chromosomes, you have an affected child. In this case, this is a daughter who are of both parents get the affected chromosome and thereby gets a severe disease. They have mild or no problems, and the affected daughter has as you can show here, has a severe disease. So this is important to remember. It's different from hemophilia. If you have a type 1 or a type 2, the chance of getting a child with Willebrand disease is about 50%. And if you have both, their parents are both mildly affected and get a child, then the chance of having a severely affected child is 50%, 25%, 1 in 4. 2 of them will have one of the mutations, and 1 of the 4 out of 4 will have no disease. Now, just to give you some impressions there, I just mentioned already in the previous slide that there can be various mutations. So mutations are variations in the gene. They have, and that is the case from especially in type 1 disease, that you have a variable expression, and also a patient within the family, and Joe explained that very well. Some patients do have more severe bleeding episodes than others, despite the fact that they have the same disorder. And that is partly caused by, for instance, activities that a patient undertakes. If you are a soccer player, yeah, you might have more bruises than somebody who's an accountant sitting behind the desk. Females have more bleeding problems than males. That is something that is very clear, especially in type 1. In type 2, you can see that there's also missense mutations, and they are located in specific domains, leading to various types of type 2 from Willebrand disease. If you have the type 2M, type 2A, type 2B, then mostly in all these patients, also in the affected family members, the disease is much more looking alike in all family members. And so the variable expression, as you see in type 1, is less clear in type 2. If you have a type 2B in the family and your father or your mother had the problem, then that you probably have the same venous bleeding problem. Type 3, complete absence of a Willebrand factor, and that can be caused by 2 similar mutations in the parents that come together in the child, or in 2 different mutations that come together in a child if the parents are not related but both have an abnormality in their Willebrand factor gene. Now, there are many variations described in the Willebrand factor gene in thousands of patients that have been studied in various studies all over the world. And these variants are now all collected in several registries. This is the EHC registry, the European Allied Haemophilia and disorders, bleeding disorders. And also from Leiden, there's a site that combines all the results of studies that have been performed in the past. And for instance, this is just an example. This is an example of a patient that has been described in one of the research articles, and it says something about the function, the exact place in the Willebrand factor gene where the problem is. And so you can find, if you are a doctor and you have done genetic analysis in a patient, you can find whether that has been described before and whether this is indeed a mutation that causes the Willebrand disease in this patient. Question is, do all patients with Willebrand disease have a gene mutation? We thought previously that if you have Willebrand disease and it's an inherited disorder, like the pedigree of Dr. Willebrand that he made, that if it's inherited, that the patients that are affected or are not affected, they all have the same genetic background. And so if you have a mutation, if you have Willebrand disease, that you should have a mutation. But that's not true. If we look in, especially in the type 1 patients, and we look whether they have a genetic mutation, then if mutant or a variant in the Willebrand factor gene is not found in every one of them. That's weird, because you would expect if you have levels less than 50% and it's an inherited disorder that there should be a mutation, but that's not the case. And Also, not every variant that we find, if there is a variant in the gene, because it's a very large gene, is a pathogenic mutation, is causative for this disease. So you might have variations in your genes that are not important and do not cause fulminant disease. So it's also very difficult to know whether this variation is really causative and making this patient a fulminant disease patient. And importantly, in type 2 and type 3, instead of what I just mentioned on type 1, mutations are frequently found, and nearly all patients exhibit mutations in genes. Now, in very large groups of patients, this is some background on what I just mentioned. In type 1 patients, there have been large cohorts, hundreds, thousands of patients have been studied now. And what you can see is that, for instance, in type 1, depending upon the country that this registry was performed and the genetic analysis, but about, let's say, up to 55 to 81% have a mutation. But there are some patients who do not have a mutation. Hey, you can see this here. 20% apparently do not have a mutation in the EU study. And we have performed in the Netherlands the WIN study, the Willebrand in the Netherlands study. And we analyzed in our first analysis 155 patients with type 1. And we sequenced and we found that 61 of them had a mutation in the fulminant factor gene. So 39% did not have a variant. And if you look at the levels of these patients, so if they had levels, let's say from 40 to 50, or from 30 to 40, that you see that the percentage of patients who have a mutation increases when the fulminant factor levels are lower. So in those patients, here depicted with between 30 and 40 and 40 to 50, you can see that the amount of patients, or the percentage of patients that have mutations, is lower. So that brings some questions, because why do these patients have fulminant disease? And it might be that other factors may lead to low fulminant factor levels. And we have done some studies, and we know now that there are some mutations that lead in other proteins that lead to less secretion of fulminant factor from the cells, and therefore the fulminant factor can be made in the cell but cannot be expelled in the blood, and therefore the blood levels are lower. So the fulminant factor gene is normal, but the machinery to secrete those fulminant factor molecules is defect, and that can also lead to fulminant disease, at least to the clinical phenotype. So that also, and that's why I am actually mentioning this also means that mutation analysis of the fulminant factor gene is not so useful to diagnose type 1. Because if you diagnose, if you have, let's say, levels as the individuals here who have levels less than 30%, and they clearly have fulminant disease because they bleed, they have low levels, but many of them have a mutation, but 20% do not have a mutation. So if we would use mutation analysis or genetic diagnosis to diagnose fulminant disease, we would classify these patients as being normal, but that's not true. So that makes it clear that mutation analysis is not useful to diagnose type 1 fulminant disease. Now, back to the diagnosis. How do we diagnose fulminant disease, and is genetic analysis always performed? Now, actually, the most important things in the diagnosis of fulminant disease is the bleeding history of a patient. Bleeding is a hallmark of the diagnosis, because if you do not have a bleeding and low levels of fulminant factor, let's say below 50%, but you do not bleed, then maybe you don't have fulminant disease at all. You just have a slightly lower level of fulminant factor and will not lead to the bleeding problems in this individual. So it starts with the bleeding history, and then we do the laboratory assessments. And there are some screening assays and specific assays and subtyping assays that we can perform. And I'm not going into detail here, but the screening assays are mostly done by the at the first moment when a patient presents with a bleeding disorder, because it can be hemophilia or it can be another rare bleeding disorder. But if you want to make sure whether it's fulminant disease, you have to measure the fulminant factor concentration, and also look at how the function of fulminant factor is. So those are the things that we normally do, but do we need to perform genetics? Now, yeah, this is a diagnostic algorithm that we have used for years in our country. So we measure first the screening test, then we do the fulminant disease assays. If the levels are low, then we do some extra assays and we diagnose or type 1 or type 2 disease, or in some cases type 3, and then we inform the patients and we give a personalized treatment protocol, as Joe was mentioning. Important, and that's why we want to diagnose it. But the word genetics is not used in this schematic representation. So we performed in collaboration with the ECOT, and that's a European Association for Laboratory Control and Quality Control of Laboratories. We asked laboratories, what kind of assays do you perform to diagnose fulminant disease? Now you can see here that all those antigen and activity tests of fulminant factor 8 is used in many labs. You can see this here. But if you look at the sequencing, it's only about 10%. So a few laboratories perform genetic testing for the diagnosis of fulminant disease. And should this be changed? Now that's the question, and that's why we have guidelines for doctors, how they should diagnose fulminant disease. And the algorithm that I just showed you of our laboratory has been changed in the past. And in 2021, and I'm not going into detail in this schematic representation, but just to show you how difficult it has become. This starts also with the bleeding history. Then if the bleeding history is positive, then you perform the laboratory assays, and based on the outcome of the laboratory assays, you perform the other assays. Actually, this is a very schematic representation how we should treat those or diagnose these patients. And on 2 occasions, the use of genetic testing is advocated. And I'll go into detail how this test and what these tests are for. Now, as I mentioned before, if we look at the fulminant factor gene and protein, we have different domains and we have different functions. And for instance, in type 2N, as I mentioned before, the problem is here in the D' domain. Those are the main sites where mutations occur. And this is based on a study published many years ago already. And many patients were sequenced, as I showed before. And then if you look at type 1, all over the gene mutations are found. In type 3, it's the same. Here you can see it in type 1, and here you can see it in type 3. But in type 2A, the mutations are somewhat located here, but most in the A and A2 domain. For the type 2B, they are all in the A1 domain, and the 2 ends are here. So you can, for instance, only look at this part of the gene if you are convinced that this patient has a type 2B mutation. So what is said about genetic testing in the guideline? Now, there's no recommendation on the need for or the utility of genetic testing. So type 1, you should not test. You should not do genetic testing. As I mentioned before, it does not say anything about whether you have the disease or not, and it does not help the patient whether he has a diagnosis or not. Type 2, the guideline panel suggests to targeted sequencing. So you only looked at the exon 28, that's the A1 domain, to diagnose type 2B. And for type 2N, actually using a specialized test which looks at the binding of fulminant to factor VIII, or you do the targeted genetic testing of certain exons in case of suspected type 2N. And it depends, of course, on the availability of various assays or of genetic testing in your laboratory. In case of our laboratory, we have those available. In the Netherlands, there are certain laboratories that are very specialized in Willebrand disease, and they can also perform this genetic testing. And it might be that other hospitals within the Netherlands send the material to our lab or to another lab, for instance in Nijmegen. And in other European countries, it might be different. And here you can see this is actually taken from that algorithm that if you suspect a patient of having type 2B, you first perform the genetic testing, and if it's positive, you diagnose type 2B. If it is negative, you perform additional tests. So here, genetic testing plays a major role in the diagnosis of type 2B, and the same is true for type 2N, where you can do or the assay as mentioned here, or you do the genetic testing as here, depending upon the availability of the tests. Then the question, of course, is why should we actually perform this genetic analysis? Now, I just mentioned for the clarification of the diagnosis of type 2N or type 2B, that is clear, but also we can use it for patients with type 3. Here you can see again that same schedule that I just showed you about the autosomal recessive disorder, where two people, carriers, the father and the mother, both have an abnormality in their fulminant factor gene, and then daughter may be affected, or the son may be affected. And what you can imagine, if you have a child with type 3, with a severe bleeding phenotype, who encounters a lot of burden of this disease, and also may be in danger, for instance, at delivery of bleeding, that if you have a second child, that you can perform genetic analysis early in the beginning of the pregnancy or later in pregnancy, so prenatal diagnosis, to see whether the genetic mutation that causes the disease in this child is also present in the fetus or the child, the neonate that will be born. So for counseling patients with type 3, you can look whether which mutation the father and the mother has, based on the fact that the child is already, one of the children is already born, and then you can decide whether or not the child is born, or at least the management at the time of delivery can be very well chosen. So this is another reason to do the genetic analysis to guide the management of pregnancy in type 3. But also in type 2, where we have a chance of 50% that a child has the disease. For instance, in type 2B, where bleeding occurs also in children that are born, for instance, intracranial hemorrhage, then you can perform genetic testing in the woman that is pregnant, and also in the amniotic fluid to see whether the child is affected. And that can help us to manage the patients during delivery. And there are also factors why we should perform genetic analysis, is to obtain, and that is more in a research setting, to obtain insight between the genotype and the phenotype of Willebrand disease. And why do some patients have more severe disease or less severe disease? Why do patients respond to treatment or not? Now here, one slide about the fulminant in pregnancy. So I told you already that neonates with severe fulminant disease may be at risk for bleeding during delivery. So in case of this increased risk of bleeding or intracranial hemorrhage is caused by the fact that these patients have low factor VIII or low fulminant factor levels. And in those individuals, atraumatic delivery is recommended. So what is atraumatic delivery? That's you can just deliver vaginally, so normal delivery of the child. You don't have to do an elective cesarean section in all patients, but you should be aware that you do not perform, for instance, a vacuum or a forceps delivery, because that may harm the child. Also important is that you can perform mutation analysis using amniocentesis. So you take with a very small needle, you you take up some amniotic fluid in the 3rd trimester. So then the child cannot be harmed, or the risk is very low that the child is harmed by such a puncture. And based on the genetic material that is in that amniotic fluid, which is of the child, you know whether the child is affected or not. And if the child is affected, you may be more careful during delivery with the child. If it's not affected, you know that you can just deliver the child without any additional measures. This should be discussed with the parents, of course. Not everyone is afraid of these bleeding problems, or do not want any further analysis of the child. But at least you should discuss this possibility with the parents in case a child with fulminant disease may be born. Now, what kind of insights did we learn, for instance, in our studies on the use of genetic information? Now, if you have for instance, type 1 fulminant disease or type 2, and you can be treated with desmopressin or DDAVP, which is frequently used to treat patients with fulminant disease. The question is always, is it depending upon every individual, or is it also depending on a mutation? And what you can clearly see, for instance, in this part of the slide, that the colors are depicting the same mutation in different patients, and you can see that these two patients with the same mutation have a similar response to desmopressin. And also patients with this mutation in blue, they have a very low response or hardly any response. And you can say now, based on a mutation, that a patient can be treated or cannot be treated with desmopressin before surgery. So that can help us without doing a DDAVP response in all individuals to see whether a patient is responsive or not. And the same goes through for family members, because if you look at the DDAVP response in various family members, and this is a more busy slide, but you can see, for instance, the red, the patients depicted in red, where you can see that after desmopressin, they have a rise in fulminant factor and slow decrease. These patients are have very high levels of fulminant factor, as depicted here, and can be treated very well. So these are the same families, and also the green are the same family. So family members respond equally to desmopressin. So I've told a lot, and I know that I've been maybe sometimes it's too scientific, but I think we can conclude by saying that fulminant disease is an autosomal inherited bleeding disorder that affects males and females equally, and because it's caused by a mutation in a fulminant factor gene, and the fulminant factor gene is located on chromosome 12, an autosomal chromosome. That means that men and women are equally affected. The chance of having a child with fulminant disease, whether it's a boy or a girl, is similar. Genetic testing is not routinely performed. Only all the details that I showed you about those responses on DDAVP, but also on the location of the gene mutations, is based on studies, scientific research. However, it's becoming more and more routine to perform it also in type 2, and not only in the type 2B and the type 2N, where it aids in the classification of von Willebrand disease, but also in type 2A. It is not useful for diagnosing type 1, so don't ask your physician to do genetic testing, because even if there is no von Willebrand factor gene mutation, you still can have the disease. And it may be useful in defining the management of delivery in case of a neonate with severe von Willebrand disease. So in those cases, genetic testing might be useful. And it provides insight in genotype-phenotype associations. So with that, I think I'm to the end of my slides, and I'll stop sharing my slides, and I'm happy to take questions.
Thank you so much, Professor Leebeek. We have received some comments, we have received some questions. We will probably take them one by one. And just to start, we have received a comment from the EHC Steering Committee member, Oliver Romero-Lux, and she addresses actually a very important question for us as the patient community, and it's not related, I mean, it's related to bleeding disorders, it's about hemophilia and women, and it's indeed something that at the EHC we are trying to advocate more and more. And we would like probably to pay more attention to this from everyone who are present here, that women still can have hemophilia. And of course, when it comes to low factor 8 or 9, they consider it as mild hemophiliacs. And when there is an inactivation of X chromosome, they can have severe or moderate form of hemophilia. I don't know if you want to comment on this, but from our perspective, it's important, and we want everyone to be aware of this. Because traditionally, of course, it has always been told that women cannot have hemophilia, but the stigma is still there a bit. But as the patient community and the European patient community, specifically in this case, as we represent the EHC, we're trying to shift this mentality into this absolutely new direction for everyone.
Daria, I'm completely agree with you, and it's a very good comment that you make. Also, women who are carriers or carry one of their X chromosomes mutation for hemophilia can have low levels and can also have bleeding symptoms. I just explained it maybe a little bit too bold, that there is a difference between hemophilia and von Willebrand disease. But I was not intending to say that women cannot have hemophilia, but you are completely
no, of course, it's just for to clarify.
It's very good. Very good.
So there is no misunderstanding. Mariangela, do you want to take the next one?
Yes, thank you very much, Daria. So before taking the other question, so I just want to stress the importance of one document that has been published by Baiba Ziemele in the chat. So you have guidelines on the diagnosis of von Willebrand disease. So if you want to know more about it, please click on this link. Then we have received a question about, so I will read it. Is there a procedure for suspected von Willebrand disease patients who live in countries where there are no laboratories facilities to send blood sample to reference center abroad for testing a diagnosis? How can we improve access to diagnosis in that sense? So this question needs to be further explored, because we have the cross-border health directive and the regulatory social security system in Europe. Those are like two channels for addressing cross-border health related topic. So first, we need to check the specific situation. So which is the country, for which country, in which scope? Is it in the scope of a trial? Is it in the scope of diagnosis? Which is the price of this diagnosis, and so on. So we need to further elaborate. The general rule is that is reimbursed what is in the framework of the basket benefit of one country. So if the country consider the service as standard, and they have like a table with the price already chosen, it could be reimbursed. But there are many ways of reading these directives. So what I can suggest to you, you will see in the chat, is to contact the reference center, so the ERN, and we can address this question properly and guiding you through the procedure. We don't have the juridical knowledge, but we can put together the stakeholders for understanding the situation. So those were comments, and I let you, Daria, taking the other question, and I'm sorry, I've answered myself to to this one.
No, that's important. I will pick some questions, and then we can be back to the comments, because there was another one from Baiba. So the question is, in the most severe cases, is it always necessary to have a genetic diagnosis?
Now, it's not necessary because as I mentioned, it may be helpful for genetic counseling. It may be helpful in case of deliveries, but the treatment will not change. So there are many patients who have a severe form of Willebrand disease and have never been tested, also in the Netherlands, because the diagnosis is clear, the treatment is clear, and there will be no additional value of doing a genetic test. So it depends on the situation, but sometimes it might be helpful to have a genetic test for instance, in a type 2B or a type 2N, to make sure that it is a type 2B, because in those two cases, the treatment is different. So if you, for instance, have type 2N, that is characterized by relatively normal surveillance factor levels, but very low factor VIII levels, you should distinguish this with a woman who has, for instance, is a hemophilia carrier, because she also has low factor VIII levels. And then genetic diagnosis should be done. And in type 2, also, as I mentioned before, this is typically caused by a surveillance factor mutation that leads to an enhanced binding of surveillance factor to platelets, and leads to, for instance, to low platelet counts, which aggravates the bleeding. And then you want to make sure that you have a type 2B or another disorder, another type of surveillance disease. And that is, therefore, we do the genetic testing. So, but those are actually the only two that are most important. And I think in most type 3 patients, especially because of the counseling, also genetic analysis is done more frequently.
Thank you. And one question interconnected: should genetic testing be done in patients with clinical bleeding history but no irregular plasmatic findings?
Yeah, no, and that's I think I should say no, because it hardly brings a diagnosis. There have been done many studies already, also in the Netherlands, where we have identified patients with bleeding disorders with a clinical bleeding phenotype, what we call a bleeding disorder of unknown cause, and what we call a BDUC or a BUC, bleeding of unknown cause. And those patients have no plasmatic findings. So if you measure the bleeding time, if you measure all the tests that I just mentioned in my slides, you don't find any abnormalities. But still the patient is bleeding and has had surgery or postpartum bleeding or menorrhagia. So you think as a doctor and as a patient, I have a bleeding disorder in this patient. Additional genetic analysis has been performed in many of these patients already, and it's very hard to find any abnormalities. There are some very rare disorders that have been diagnosed, but the advantage of genetic testing is very low, and it's of course also expensive. And if you find a mutation in one of the, then it's also not really known whether that is causative of a bleeding disorder. Because if you find a variation in fulminant factor gene and you have normal levels, then it is not fulminant disease. So I think I would be very reluctant to do genetic tests in patients with bleeding disorders of which we do not have a cause.
Okay, thank you so much. And there is a very nice comment that we have just received that today in Albania, apparently there is Teachers National Day, and our attendee thanks a lot, dear professor, for this amazing lesson that you are giving to everyone. And I want to read a very sensitive message always for me. It's from Baiba about her story, and I would like to ask Joe to comment on this because I know that you're aware of many other stories of von Willebrand patients, and after I read it, I want you to tell how often you hear something like this, and just to share probably some others. So Baiba writes, my type 2M was possible to diagnose only through genetic test. It didn't show up in the lab assays. Also, multimeter analysis didn't give answer. I had to advocate for national rare disease plan to have possibility to have access to genetic testing. I got my diagnosis finally confirmed only 2 years ago at the age 39. So, Joe, how often do we hear something like this? And is it a typical story for von Willebrand patients?
Hi, yes. Well, obviously I completely sympathize with what Baiba's saying. I was 37 myself before I got a diagnosis, and I literally had written on my notes undiagnosed bleeding disorder, but nobody had actually done any tests to find out if it was von Willebrand's disease. And they tested me for haemophilia, but they hadn't actually tested me for von Willebrand's disease. And and that was a while ago. And I think one assumes that the message is spread that this is potential cause of people who have bleeding symptoms. But even now, I am still getting a lot of emails from people who have got significant bleeding symptoms, and they are trying to get a diagnosis, and they're going to their GPs and they're telling their GPs that they have these symptoms, and they just can't get the referrals to hematologists. And they're being told that if they had von Willebrand's disease, then it would have been picked up at birth. They are being told, and this is in the UK, that has a healthcare system where you would anticipate that they have quite good knowledge of von Willebrand's disease and good treatment options. And yet I had a family of 3 women only a couple of weeks ago, and they have been trying for 2 years, going backward. The mother had hemorrhages after every pregnancy, and they were all had heavy bruising. They had nosebleeds, they had bleeding gums, they had the girls, the 2 teenage girls had periods which literally lasted nearly the majority of the month, 20 plus days every month. And they went to their first GP, who said, no, it's impossible. You can't have von Willebrand's disease because we've done a clotting screen. Now, we know that a clotting screen in itself will not pick up von Willebrand's disease in a GP surgery. but they were dismissed as, no, you can't have von Willebrand disease. They then went to see a second GP, and the second GP also said, no, if you had that, it would have been picked up at birth. And then they went and changed their GP completely because they were desperate, and went to the third GP, and the GP said, no, it's just a hormone disorder, and basically put both the girls on the pill. So we've got a family there who is desperate for a diagnosis, but the eldest girl's gone to university, and I actually wrote her a letter to send to her new GP at university. And hurrah, we've actually managed to get her referred to a haematologist in the city where she is at university. So hopefully now she's going to get access to some care. And actually, it's a little bit like a rolling ball, that once we have one diagnosis, we find everybody else in the family then has the access to that potential diagnosis as well. But it's like we always say, isn't it, Daria? We have people who are literally bleeding their way to diagnosis, because until that happens, we really have primary healthcare givers who are the gatekeepers to access to these diagnoses. So depressingly, no, it's not an unusual story, and I've given you one example there, but I hear it constantly. And this weekend I was at chairing Talking Red, and again, we're a room full of women all swapping very, very similar stories. And when the doctor who was speaking at the time said, what about the GPs? There was a collective, because they feel that, you know, it has been such a struggle to get the diagnosis, and then once they've got the diagnosis, to get the right treatment at the right time.
Thank you, Jo. And I think it's also important that you shared this, because it's a message probably to other patients who are present here, that you can always contact your local bleeding disorder community to ask for help. And Jo just provided an example how we, as organizations in hemophilia or other bleeding and other bleeding disorders, how we can be of help. And there is a
Can I comment? Can I comment?
Yes, of course.
Sorry. Because we performed a study in 1,100 patients with a bleeding disorder, so autosomal bleeding disorder. So many of those were patients with Willebrand disease, and we looked whether at the so those are patients that were diagnosed in the past, and we looked at the time of first bleeding and the time that they were eventually diagnosed, just like Jo is telling us. And we found that in those individuals, the delay between the first bleed, which was about at the age of now, I think 8 to 9 years old for boys and for girls, there they had the first bleeding on retrospect, and the delay was 7.7 years for males and more than 12 years for females. So then the diagnosis was made, and that's a scientific report, which was published in one of the Lancet papers, eClinical Medicine, and it shows us how long it takes before a diagnosis is made. So it's still, and that is in the past, but it still happens. So I completely agree with all of you. We should advocate that patients who have a bleeding disorder, and especially women who have bleeding problems, should be referred. And it's not a difficult diagnosis, but we can save a lot of burden of the disease, and save a lot of energy for these women and bleeding symptoms by giving them treatment because of this Willebrand disease.
Thank you very much. And related to what you're saying, there is one other question. When is it recommended to measure von Willebrand disease after birth?
Yeah, that's a very good question. that depends on the type of von Willebrand disease, because we know that, for instance, in children with von Willebrand disease type 1, when they have levels, let's say, of 30% to 40%, then at the time of birth, there is a lot of stress involved, not only for the mother and the father, but also for the child. And stress leads to very high levels of von Willebrand factor. So if you would measure von Willebrand factor, let's say directly after birth, then you would find normal levels. And that is not true, because in a normal situation, in a healthy situation, in a steady state, then this child might have von Willebrand disease. So we always tell the patients to come back after 1 year, when the child has grown up a little bit, and then we can draw blood and make the diagnosis. Sometimes we need a second measurement because the levels change a little bit over time, but then at least the diagnosis can be made, or patient can be healthy and do not need to have any further studies. For patients with type 3, if a patient is suspected of having type 3, then we can do von Willebrand factor levels. We can measure it in the umbilical cord. That's one option. And also perform a venipuncture directly after birth, because you want to know immediately whether the child is affected or not. And for the other types, it also depends. In type 2B and type 2A, you can also measure it in umbilical blood, but sometimes you get some disturbing results, because von Willebrand factor is difficult to measure in these fluids. So you can also postpone it to, let's say, at 1 year. Only if a patient needs, or a child needs, to undergo surgery, for instance, in the first year, then I would do it always before the surgery is performed.
Thank you so much. I don't see any other questions in the chat for the moment. Do we have anyone raising hands? Doesn't seem so.
Maybe waiting if other questions arrive, we can advertise next session. So it will be at the end of this month, so on the 28th of March. We will continue exploring the von Willebrand disease area. And so we are going to talk about type doesn't define von Willebrand disease symptoms. And with us, we will have Professor Rita Lassila from Helsinki University and Hannah Yarnall from UK Haemophilia. So we gave you this appointment in some weeks. And by the way, I think that today at this webinar, a part of learning a lot, and thanks again, Professor Leebeek, of clinical aspect of the disease, we also saw the importance of advocate for one's rights. The testimonies from Jos and from Baiba really stressed the importance of raising the voice and really looking for a network and help and assistance. And we also really hope, all together with the building of this webinar, also to spread this awareness of what exists in Europe in terms of expert, patients advocate and network that try to put everyone together. So thanks a lot for your testimonies on that also. It's really, today it's been really evident, the strength of asking and raising the voice for one rights, that is community rights also. Okay, so I see thanking and compliments.
Yeah.
Thank you. Thank you very much. Okay, so
we can wrap up.
Yes, we can wrap up. So you know the dates of the next session, and we hope to see all of you. And before closing, I want to thank a lot of people. So I'm lucky of being surrounded of such dedicated person and devoted person. So thanks first of all to the speaker of today for having sharing their time and expertise with us. Then thanks a lot to my colleague Daria Camilli from the EHC for organizing with me this webinar. Thanks a lot to Baiba Ziemele, ePAG of the ERN, and not also, not just ePAG of the ERN. So thanks a lot to all of you for today's webinar and for the organization of this program. Thanks very much.
Thank you, Mariangela, and thanks to the ERN-EuroBloodNet for initiating and for organizing this program together with patients. And that's an amazing initiative, and it's indeed unique because it hasn't been created before. It's unique in the sense that we have a duo of a patient and a clinician answering the questions together and equally, and the audience learning from the experience of patients and from the scientific knowledge of a clinician. And that's absolutely amazing. And we will continue with this. And we have many more webinars to come. So please come and learn and provide your feedback after this webinar.
Thank you.
And my personal thanks to Mariangela.
It's mutual.
Bye.
Thank you very much. Have a nice evening. Thank you.
Bye-bye.